I'd like to do in the next 30 minutes or so is discuss with you addressing diabetes as part of the strategy for ending tuberculosis. And how I thought I'd tackle this is by looking first at the global epidemiology of both diseases, show you how they interact, explain what the global response is to this interaction, and then look at the various components of that global response and see how they fit into the pillars that support the NTB strategy. So let's remind ourselves once again of these SDGs. So 17 of them, 169 targets. For health, we have one goal, SDG 3, with 13 targets. And for tuberculosis, this fits into SDG 3.3, where countries have committed to end the epidemics of AIDS, tuberculosis, and malaria, and neglected tropical diseases by 2030. For diabetes, this fits into SDG 3.4, where again countries have committed to reduce by 1/3 premature mortality from non-communicable diseases by 2030. A daunting task ahead, I think. Because if we look at the global burden of these two diseases, it's really immense. These are the figures for 2014. So for diabetes, nearly 400 million people living on the planet with this disease, 10 million new cases per annum, and nearly 5 million people per annum who die of diabetes-related complications. If we look at tuberculosis, a disease that about 35 years ago I remember was to be confined to the history books, it's not doing too badly. 13 million people living with the disease, 9.6 million new cases, and 1.5 million deaths. So if we look at where these diseases are distributed, of course everybody knows that TB is largely a disease of people in low-income and middle-income countries. I think what is not so well known is that 3/4 of the diabetic burden globally also occurs in low and middle-income countries. Indeed, India and China head the league table here. So if we take India, it has the dubious distinction of having the highest number of TB cases per annum in the world and the second highest number of diabetic cases. If we go to China, China has the dubious distinction of having the highest number of diabetic cases in the world and the second highest number of TB cases. They both have something in common. So out of the 400 million people living with diabetes, half of them almost do not know that they have the disease diabetes. And similarly with tuberculosis, 38% of patients with tuberculosis in 2014 either were not diagnosed or they were diagnosed but not notified to national TB control programs. And then finally, with tuberculosis, since basically 2000, the last 15 years, we've had a gradual decline in TB incidence, albeit quite small at about 1% per annum. But with diabetes, we've had an escalation in this diabetic epidemic. And by 2030, it's predicted that we will have over 550 million people with diabetes on the planet. So what about the interaction between these two diseases? Now, we heard earlier this morning that the number of people carrying MTB is 2 billion, maybe a bit less, maybe 1.5 billion. And we know that those people have a lifetime risk of getting active TB that is about 5%, maybe up to 15%. The risk being highest in the first 1 year or 2 years after infection. Now, that risk is increased in certain circumstances. Of course, the extremes of age, HIV/AIDS, which is the strongest risk factor known to man. And then we have other causes, so silicosis, malnutrition, smoking, alcohol, and diabetes features here as well. Now, this link between diabetes and TB actually has been known about since Roman times. In the classical literature in Latin, it is written that people who passed a lot of urine, people whose urine was sugary, had an increased propensity of a consumptive disease that sounds very like tuberculosis. And between Roman times and really the last 8 to 9 years, there have been anecdotal reports, case studies looking at the interaction. but in fact, precious little interest at that time. And I think it's because people think or thought that diabetes is a disease of rich people living in rich countries and is a minor problem in the low and middle income countries where TB is prevalent. But there's been a radical change in thinking. First of all, we have much better scientific evidence now of interaction, and I will come to that. Secondly, we have this rapidly growing epidemic of diabetes in low and middle income countries, particularly amongst the urban poor, which is where TB flourishes. And then finally, we have this much slower decline in TB incidence than predicted by epidemiological modeling. Using the DOTS, the Stop TB approach, we should have seen a much greater fall in TB incidence than we have actually seen. So there are things preventing this, and maybe diabetes is one of the factors, along with others, preventing this decline. So I think the two important publications here were firstly by Catherine Stevenson from the British MRC, working with her WHO colleagues, publishing in Chronic Illness 2007, and then Christy Gion and Megan Murray from Harvard University in the States, publishing in PLOS Medicine the year later. Both of them did systematic reviews and meta-analysis over slightly different time periods, but both concluding that diabetes mellitus increases the risk of tuberculosis by a factor of 2 or 3 times. Now, since those publications, there have been other papers confirming this association, confirming this degree of risk. There's also growing evidence that in people with diabetes, if they have poor diabetic control, that further increases the risk of TB. And recently this year from Taiwan, a study showing that if you have diabetes, you have enhanced case management, good diabetic control, that risk of tuberculosis goes down. So I think we have to first ask, does this biologically make sense? And the answer is it does. We have animal models. For example, you can make mice diabetic. Those mice have impaired cell-mediated immunity. And if you infect them with Mycobacterium tuberculosis, they have much higher loads of MTB compared with normal mice. Secondly, in patients with diabetes, quite a lot of work done on their immune systems. They have impaired cell-mediated immunity and also poor lung defenses against MTB. Does the interaction matter? And again, I think the answer here is yes, it does. With this pandemic growing of diabetes, we will probably begin to see more diabetic-associated TB cases. Also, we know that we get worse TB outcomes in people with diabetes. So let me just show you this data from WHO in 2012, where they estimated the population attributable fraction of diabetes for adult TB, coming to the conclusion that this was round about 15%. So giving us in 2012 just over 1 million adults globally living with TB and diabetes. That's just a little bit less than the 1.1 million people living in the world at that time with HIV-associated tuberculosis. And if you look at the countries mainly involved, of course, not surprisingly, India tops the list here with about 300,000 adults with TB and diabetes. China next with 150,000. Interestingly, South Africa next at 70,000. And then we have a range of large Asian countries, Indonesia, Pakistan, Bangladesh, and the Philippines. Now, Megan Baker and colleagues in 2011 did a very nice systematic review, meta-analysis, looking at the effect of diabetes on TB treatment outcomes, and coming to 3 conclusions. Firstly, that diabetes is associated with a possible delay in sputum culture conversion, although not all the studies are consistent in this. Secondly, that diabetes is associated with an increased risk of TB failure and TB death during treatment, a lot more consistency here. And finally, that diabetes is associated with an increased risk of recurrent tuberculosis after successful completion of treatment. All of those 5 studies finding a positive association. There's also growing evidence that in diabetic persons with poor glycemic control, they have even worse TB treatment outcomes compared with those who have good control. And again, this study from Taiwan by Lo et al. Showing that enhanced case management of diabetes reduces, mitigates that risk of death during TB treatment. So that's the interaction. So what has been the global response to this? In November 2009, an expert meeting was convened in Paris at, in fact, our union headquarters between WHO, the union, the World Diabetes Foundation, the International Diabetes Federation, academia, ministries of health. It was a 2.5-day meeting with some good outputs, one of the outputs being the research agenda to tackle this dual burden of disease. But an important output was agreement to go forward and develop, write, publish, and launch a collaborative care framework. So indeed, in August 2011, WHO and the Union launched this collaborative framework for the care and control of TB and diabetes, following very much the sort of WHO model or WHO policy on TB HIV collaborative activities, which was first published 2004 and then again in 2012. So essentially 3 themes of work here. First theme is to establish mechanisms of collaboration between the NCD world and the communicable disease world. Secondly, to detect and manage TB in patients with diabetes. And thirdly, to detect and manage diabetes in patients with tuberculosis, what we call bi-directional screening. And in this framework, there was a clear call for more operational research, more research to build up the evidence base about the interaction and what we're going to do about it. So I'm pleased to say in the last 4 years that's had a desired effect. There's been a plethora of studies now published on diabetes TB here, many of them reporting on diabetes prevalence in TB patients, and I've given you just a snippet. So Texas, Mexico, high rates, 39%, 36%. Southern India, high rates of about 40%. In Kerala, Karnataka. And then in the South Pacific, you have a raging epidemic going on, where up to 50% of TB patients in that big region have diabetes. So what I'd like to do now is just quickly say, look at those components of that response and see how they fit in to the NTB strategy. So just remind ourselves about this NTB strategy. We have 3 important indicators. Firstly, we will reduce TB incidence compared with 2015 by 80% by 2030 and by 90% by 2035. We'll reduce the number of TB deaths compared with 2015 by 90% by 2030 and 95% by 2035. And during all this time, we expect to have no families facing catastrophic financial costs as a result of tuberculosis. So these are the 3 pillars. I think we saw them earlier this morning, Pillar 1, Pillar 2, Pillar 3. Pillar 1 is essentially the technical components of TB control, focusing on early diagnosis, screening of contacts, high-risk groups, treatment, collaborative activities, management of comorbidities, prevention, vaccination. Pillar 2 is around bold policies and supportive systems, and Pillar 3 is basically about intensified research and innovation. So let's look at Pillar 1 and look at this component, early diagnosis of TB and screening high-risk groups. So here we can fit in quite nicely our screening of diabetic persons for TB, focusing this in countries with a TB prevalence of more than 100 per 100,000. Now, we've been, in fact, doing this in the routine health services in countries in India, in China, in the South Pacific, also in some other Asian countries. So this is a way we've been trying to do it in the routine system. So let me explain it. Diabetic patients generally come to the clinic once every 3 months for review. So we screen them once a quarter, once every 3 months. And when they come, we ask a very simple question: has TB been diagnosed during this last 3 months? And if the answer is no, then we screen for positive symptoms of TB. Very simply, we ask them about cough, fever, night sweats, and weight loss. And anybody who has positive symptoms is referred for basically investigation, TB diagnosis, and care if they have TB. So let me give you a snippet of what we found working in India in 2012 in a number of diabetic clinics. So this was Q2 2012. So just over 12,000 diabetic patients seen in this quarter, and 74 of them said, I've been diagnosed newly with tuberculosis in this quarter from elsewhere. India has a very good coverage of DOTS programs throughout the country, and they were diagnosed in some DOTS center. That left the remainder who should have been screened. And as you can see, this didn't work very well. Only half of the patients were asked 4 simple questions. Of those, a small number had a positive symptom screen. Most of those were referred for TB investigations, and just less than 10%, 11 patients, were found to have newly diagnosed tuberculosis. But as a result of this exercise, you can see we picked up 85 new TB cases during the quarter. And if you break this down to the usual parameters used in TB control, this is 695 TB cases per 100,000 diabetic patients screened per quarter. That's a much higher rate of pickup than usually found in the passive case-finding strategy used in that large country. However, big challenges with this. First of all, diabetes doctors clearly not very interested in this work at all. We have a poor sensitivity, as we know, of sputum smears and x-rays for diagnosing tuberculosis. That symptom screen is focused on people with pulmonary disease. So what about extrapulmonary disease? Do these people slip through the net, so to speak? And finally, we have no proper monitoring, recording, reporting systems in diabetic clinics, in complete contrast to what we have in the TB clinics. So it's very difficult to get decent data. I think we also need to know, is the newer TB technology cost-effective in this situation? Should we be using expert MTB RIF for doing our screening? How often should we screen? Is once every 3 months just too much? Should we do it once every 6 months or once a year? Should we use a more targeted approach and just go for diabetic persons who we think are at risk of tuberculosis? And should we screen for latent tuberculosis? So drawing on what Alison talked about earlier. At the moment, WHO does not recommend that we screen for latent TB in people with diabetes. There's some new evidence that has just emerged. So the risk of TB is higher 1 to 2 years after the diagnosis of diabetes has been made, maybe because diabetes is out of control at that time. And the risk of TB is higher in those, not surprisingly, with greater TB exposure. So, for example, diabetic persons working in health facilities, those with poor glycemic control, with heavy smoking, and with high alcohol consumption. So let's go back to Pillar 1 and look at this other aspect of treatment and managing comorbidities. So here, the screening of TB patients for diabetes and treating patients with dual disease fits very nicely into this component of Pillar 1. So again, going back to India, China, South Pacific, other Asian countries, this is how we've been doing it in the routine health system. So TB patients come in, they get registered. We ask them very simply, do you have a known diagnosis of diabetes? And if the answer is no, we screen first with a random blood glucose, RBG. And if the random blood glucose is at or above 6.1 millimoles per liter, this means the person is at risk of having diabetes. So then we need to bring that person back and screen with a fasting blood glucose. And if the fasting blood glucose is at or higher than 7 millimoles per liter, then we can diagnose diabetes and we can refer to diabetic care. So let me give you, again, going back to India, we ran this in the routine health services it was about 60 health centers, about 6, 7, 8 hospitals over an 8-month period. So 8,000 TB patients registered during this time. You can see that 8% of them said, yeah, I already have diabetes. I'm known to have diabetes. I'm on treatment. And the rest needing to be screened. And in contrast to the other way, this worked quite well. You can see that 98% of patients, in fact, got a random blood glucose. 2,800 needed a fasting blood glucose, and 95% of them got this investigation, ending up with just over 400 newly diagnosed diabetic patients. If you put all this together, this little exercise pulled out basically over 1,000 diabetic patients, most of whom were referred for care and for treatment. Now, very interestingly, this was done in conjunction with the Ministry of Health in India, and was presented back to the director of the National TB Control Program, the director of the Non-Communicable Disease Program. Very impressed. They said, listen, we have a major problem in this country. So the Ministry of Health issued an immediate directive, an immediate policy decision that from henceforth all TB patients in India, all 2.2 million every year, are to be screened for diabetes using glucometers and referred to diabetic care and treatment. Now this requires, once you have a policy decision like this, quite a lot has to happen. The TB treatment cards used in India had to be all revised. So the back of a treatment card, you can see that box at the bottom, just here, that shows HIV status. Well, this had to include diabetic parameters, who's been screened and what are the results of screening. Similarly, the registers that are everywhere in India in the dot centers had to be changed. The right-hand page of a register had to have now a new column next to the HIV column to indicate had you been screened for diabetes and did you have diabetes, yes or no. And the quarterly reports also had to be changed. So, of course, every quarter you report on the number of TB patients registered, but also now they have to report on the number of TB patients screened for diabetes and the number of TB patients diagnosed with diabetes. Now, of course, going from policy to changing things to practice takes a bit of time. So if you look at that huge country, not much has happened in many states, but a few states have implemented this, particularly in the southern part of India. So Kerala has done quite well. So let me just give you 4 years' worth of data from Kerala. So in green, I hope I got my colors right. I'm colorblind, so I can't really see these colors very well. But in green, it shows you the number of TB patients registered every year, and in orange or red, along with the percentages, shows you the number and percentage who have been screened for diabetes. So you can see that over 4 years, this was not bad. It rose from 27% to nearly 90% in 2013. And in terms of pickup, not bad. So 24% of TB patients screened in 2010 had diabetes, and this has plateaued and been fairly consistent for the next 3 years at around about 18, 19, 20%. So a high yield of diabetes through this exercise in Kerala. However, challenges. So one of the challenges is when should we do the screening? Should we do it at the time of registration of TB patients, or do it at the end of the initial phase of TB treatment, or at the end of the continuation phase of TB treatment? And the issue here is that TB is a chronic infectious disease. It causes chronic inflammation. It puts stress on the system, and that stress raises blood sugar levels. So, of course, you can make a false positive diagnosis of diabetes. The problem is that if you wait for that stress to go down and you screen later on in TB treatment, you miss the opportunity to do anything about diabetes if it's obviously 2 or 3 months down the line, and you might not be able to affect TB treatment outcomes. So that's one issue. The second issue is how best to do this screening. Now, should you do it clinically? Should you use just a urine dipstick? Very simple. A random blood glucose on its own. A fasting blood glucose, which of course means the patient has to fast, has to probably come back for a second appointment. A glycated hemoglobin, or an oral glucose tolerance test. Now, as you move from top to bottom, those tests become a lot more specific and a lot more sensitive. But as you move from top to bottom, they become more cumbersome to do in the routine situation, and they become more expensive, particularly a glycated hemoglobin. So somewhere you have to find the right balance for routine health services, routine program implementation. So fasting blood glucose seems to us to be a good way forward, but we do know from work done in China that this misses half of the patients identified through an oral glucose tolerance test, and we know in comparisons with glycated hemoglobin, it misses something like 25–30% of patients picked up using glycated hemoglobin. So there's benefits and risks for these approaches. In terms of treatment, we also have several challenges. Now, all TB patients globally now get 6 months of anti-TB treatment for drug-susceptible disease. So the question is this adequate? There's some preliminary evidence, not great, that 9 months is better than 6 months. This needs to be studied. What are the best drugs for optimal drug concentrations, knowing that rifampicin has an effect on oral sulfonylureas and reduces their concentrations? We have drug disease toxicity. So, for example, isoniazid and metformin work together to increase the risk of lactic acidosis, which is potentially fatal. Drug disease toxicity, we have isoniazid and diabetes causing both of them peripheral neuropathy. What about TB infection control in diabetic clinics? If you have TB patients sitting undiagnosed in diabetic clinics, are we preventing nosocomial TB transmission? Recurrent TB, is this reactivation or is it reinfection with a new strain? And finally, can we, in these busy TB program clinics, integrate lifestyle modification education, if you like, try and get people to stop smoking and try and get people to alter their diets? There's a bit of new evidence in the last year. Interestingly, metformin, which is an old established anti-diabetic drug, may augment the host immune responses to Mycobacterium tuberculosis. Some nice work being done in Singapore here, and that work being further done to see really whether metformin might be something you could add even to non-diabetics to augment the treatment against tuberculosis. In Mexico, 20% of recurrent TB in Mexico was due to reinfection with a different MTB strain. So the question is, where did those people get their TB from? Maybe from the community where they got their TB in the first place, or maybe they picked it up from a diabetic clinic. And my colleague Lin Yan went around 10 diabetic clinics in China looking at infection control measures and finding these really to be quite inadequate, particularly with regard to airborne transmission of infection. Let's look at Pillar 2, supportive systems, high-quality integrated care. So here we could think about integrating diabetes TB care. So the normal situation, I'm afraid, is what you see on the left, where if you have both diseases, you will go to the TB clinic for your TB treatment, and then you'll have to wander either in the same hospital or to another hospital to get your diabetic care and treatment. Surely we can integrate. We had this debate long ago with HIV/TB. Surely we can follow that model. And indeed in Mexico, where they did this, they integrated diabetic care into the TB clinic. You had much better clinical outcomes, much better TB treatment success than basically having two separate clinics manage this. Again, Pillar 2, prevention by addressing underlying determinants. So here, what about thinking about better diabetic prevention and better diabetic care? So I take you back to these targets. Now, if we look at the MDG targets from 2000 to 2015, we had an 18% overall decline in TB incidence. Now, we've now set ourselves a fairly staggering target between now and 2030 of an 80% decline in TB incidence in the next 14 and a half years. Now, people have done modeling, and Pan et al. Have looked at the diabetes epidemic on this, And they predicted with their modeling that TB incidence would decline by 8.8% only by 2030 if we have the current diabetic epidemic progressing as it is currently progressing. And they said that if we were able to get a handle on this, we could basically improve that decline by maybe up to 20%, but nothing like 80%. So how do we begin to do this? Now, I put this up here to show you that I think HIV TB, diabetes TB share some things in common. If we look at both these associations, we have an increased number of TB cases as a result of the association. We have more difficult to diagnose TB cases. I haven't shown you this data, but in those people with diabetes, you tend to get much more lower lobe involvement and more infiltrative disease, a little bit like you see with HIV. And of course, you get worse treatment outcomes, death, recurrence, and failure. With HIV TB, of course, you get a much, much stronger individual effect compared with diabetes. But don't forget that at a population level, we have 10 times more diabetic people in the world than HIV-infected people. So we need to begin to think about tackling the upstream issues. Now, with HIV, I think we're not doing too badly. I sort of feel we're getting a handle on the HIV epidemic. We've got behavior change schemes. Condoms are being used, not by everybody, of course, but by high-risk groups. Male circumcision is rolling out in Africa, and we're doing well with antiretroviral treatment. Early use of ART is being promoted now by WHO, and ART is being used as an HIV prevention tool. And in Southern Africa, it's quite clear to me, basically Southern Africa probably accounts for 50% of the HIV-TB burden globally. And if you look at countries like Malawi, Zimbabwe, Swaziland, Zambia, since ART scale-up started in earnest, the TB case notification rates have really come down. Malawi's TB case notification numbers have gone from about 29,000 at the peak, now down to about 16,500 per annum. And this is with massive ART scale-up covering probably now about 55% of people in need. So can we do the same sort of thing with diabetes? I think it's a lot more difficult, because here we have to tackle diets, we have to tackle exercise, we have the obesity epidemic to deal with, and of course people are saying, well, what about picking up impaired glucose tolerance, IGT, detecting it and preventing people going on to get diabetes? What's the evidence that that works? It's pretty slender. So I think we have a difficult task here. Finally, Pillar 3, research and innovation. So here, new technology, operational research. Let me just say a few words. To me, I think if I look at the NTB strategy, the main problems, I think, are early diagnosis of TB, or diagnosis at all of TB, treatment, particularly, as Derek mentioned, about treatment of MDR TB, that's a major problem we have, and of course, scaling up preventive treatment for tuberculosis. And we've touched on some of this today, but for new technology, I think we need other biomarkers to tell us who with latent TB infection may go on to get active disease, who would require treatment. We need new point-of-care TB diagnostics. I mean, expert is great, but expert is laboratory-based. And my own feeling about this, having worked in Africa many years, is that we've got to move out of the laboratory and then get coverage basically at health centers in the community with trying to diagnose TB. And then maybe we'll get a handle on these 3.6 million missed cases. We need new and safer TB drugs, and we heard from Derek about what's in the pipeline. We need to know how those drugs interact with diabetic drugs. And finally, of course, we need a better preventive vaccine than BCG, and thank you for your great talk earlier today. I'd like to just mention the TANDEM Consortium. This is an EU FP7 funded consortium led by the London School of Hygiene and Tropical Medicine and by Radboud University in the Netherlands, doing great work. They're doing field work, looking at bidirectional screening and clinical treatment of people with dual disease in Peru, Romania, South Africa, and Indonesia. And then in the laboratory, looking at biomarkers, looking at in vitro work on monocytes, macrophages, T cells, adipocytes, and also genetic studies to try and unravel and try and understand the causal link between diabetes and tuberculosis. And really, I think this is important and hopefully will give us some useful evidence in the next year or two to come. So let me sum up, Jerry, just to say that then with diabetes TB, we have this rapidly growing pandemic of diabetes, and I think this could threaten the NTB strategy by increasing the number of TB cases, by increasing case fatality, and by increasing the risk of failure and relapse, which feed back to those first two. We have a global framework in place for collaborative activities, but we need much more country-level action, and certainly we need more research to understand the interactions between these two diseases and what to do about it. And I'd like to finish by saying that in November last year, about 120 people, I went as well, went to Bali, Indonesia, to discuss what should be done about the diabetes TB epidemic. And they came up with what's called the BALI Declaration. These were people, high-level people from governments, from NGOs, from civil society, advocacy organizations, industry, and also research institutions. Basically saying this was an important problem. We needed to strengthen the collaborative framework for care and control. We need now a much more robust research agenda. We need political commitment, advocacy, and so on. But also an understanding that to tackle these two diseases, we need to work under a much broader framework and address these other SDGs that focus, for example, on poverty, clean water, cities, and we need strong global partnerships. And maybe if we do address these, we'll begin to get a handle on essentially communicable diseases and non-communicable diseases and their interaction. So thank you for your attention.